myself and Professor Alan Salama are going to talk a little bit about just in general what IgA vasculitis is, but more importantly when a kidney specialist might be needed, and that's for children, which I'll be here representing, and also for adults with the disease. Will then be followed by Professor Hedrick, who's a paediatric rheumatologist at Alder Hey Children's Hospital, and he's going to talk a little bit about more unusual cases where there might be persisting or relapsing disease, and when might you need a specialist rheumatologist to be involved in your care. I'm very grateful to Zoe joining us from Vasculitis UK to talk a little bit about how we work very closely with our charity partners to support patients and what patient support might be available from Vasculitis UK. We'll then have a very brief break, so if anybody wants to go to the toilet, that's your time to go to the toilet. And we're very grateful to be joined by amazing Stephen, who's actually a magician who's moved his tricks online for half an hour just to break up the session and allow people to think of any questions that they might have or any reflections on their experience and their journey with HSP so far. And then we'll do the discussion through Ask the Panel, using those questions or anything that's been texted into us to answer some of the questions that people might have, or just, you know, express concerns that might be shared across lots of different people. And then very briefly, I'm going to mention on a research study that we are in the design stages of, that we would like some patient input on, and then we'll close and finish the session and get some feedback. So that's roughly the plan for this morning, and please feel free to dip in and out as much as you want. So we're going to talk a little bit just in general about IgA vasculitis, but more importantly about when a kidney specialist might be needed to be involved in your care. So what is IgA vasculitis? Well, it's previously been called HenochSchonlein Purpura or HSP, and the names are used interchangeably. And a few years ago, the name was actually changed within the medical literature to try and represent the biology that might be happening. And so that's why now you see lots of terms and people using the word IgA vasculitis, but actually they're exactly the same thing. And it's just changed from naming the biology from HenochSchonlein Purpura, which were actually the doctors who originally discovered the disease. But in almost all cases of IgA vasculitis, it presents with a rash and a little bit like you can see here with Homer Simpson. It's often not exactly how Homer is. It's usually more on the ankles and on the lower legs, and it's what we call a palpable purpuric rash. And this is a rash like other types of vasculitis where it doesn't blanch away with the glass test, and lots of people are familiar with the glass test because of all of the awareness of meningitis. And so if you were to have a glass and roll it over the rash, it doesn't blanch away, it stays there and you can see it through the glass. And so usually we see, particularly in children, that rash will take people to go and see a doctor fairly early on, or to go to A&E, and some people will get treated as if this is meningitis or infection before they actually get to the diagnosis of it being HSP. And together with the rash, we often see 3 other areas in the body that are involved. And this can be the gut or the tummy, where we can see abdominal pain, sometimes vomiting, sometimes diarrhea, and occasionally very severe problems with blood in the poo. We also see sore joints, and in particular the joints around where the rash might be involved, so sore ankles or sore knees, and sometimes this soreness has swelling associated with it. And the third area that we see involved is the kidneys, and usually the kidneys actually are hidden away, and the only way that we can tell that the kidneys are involved is by checking the urine. And so everybody who gets a diagnosis of IgA vasculitis should be having their urine checked. So why does this happen? When we look at the biology of why this might happen, in everybody, in all of us, we have this immune molecule called ImmunoglobulinA or IgA. And this molecule lives in our mouth or in our gut, and it helps to fight germs when we might get germs in our mouth or germs in our gut. And IgA is produced to try and help fight these germs and help your normal body recover so that you don't get infected. And what happens in people with IgA vasculitis is that the body will produce this IgA, but it's slightly abnormal, and it therefore is detected by your own immune response as something like an invader, and your own immune response produces this autoimmune reaction to it. So your own immune response is actually reacting to an area of your immune system because it's slightly abnormal. And then what happens is that we see what we call antibodies against this abnormal IgA, and they can circulate around in the blood and they can deposit in different parts of the body. And it's usually the areas with the small vessels, because it's a small vessel vasculitis. And so that's why we see the small vessels in the gut, in the joints, and in the kidney are affected. Because IgA lives in the mouth and in the gut, sometimes it can be triggered by a throat infection. It could be triggered by an upper respiratory tract infection, so a cough, cold. And it can also be triggered by anything that might be causing any inflammation within the mouth or the gut, so a gastroenteritis or dental caries or poor dental hygiene. And so sometimes when we see people who have very persisting disease, we will try and look a little bit harder to see if there's anything that might be triggering it that's meaning that the disease isn't settling itself away. But it also means that after a common cold or a common sore throat that we do see it can trigger IgA vasculitis. So what happens? For the vast majority, it's actually fairly good news, and most people get better from this. Now, we know when we've held these events before that actually most people who get better don't usually log into these types of events, because those people get better, it's all gone, and they've forgotten that it's happened. And usually we have people who have more unusual and atypical disease. And so whilst it's great that the majority get better, we also need to focus on what happens to that small number who might have further problems. And what we see is that a small minority can go on to get kidney problems. And this is more unusual, but it is something that can happen. We also see that some people can go on to have recurrent episodes or persisting disease. And this is an area that will be discussed in the next talk. So what do we do for kidney problems, and how can we look for them? So all patients, whether you're an adult or a child, when you present with IgA vasculitis and get a diagnosis, should be having urine checks for at least 6 months. And what we're looking for mainly is blood, but also protein. And the protein molecule is a fairly big molecule for the kidney to be leaking. And so it suggests to us that the kidney is leaking protein, which gives kidney doctors the suspicion that it might be inflamed in the kidney as well. If we see lots of protein in the urine, then we go on to do what's called a kidney biopsy test. And this involves a needle going into the kidney to get a small sample of the kidney tissue that's then looked at in the laboratory. And under the microscope, we can look at how inflamed the kidney might be. And we get pictures a little bit like this pink picture here, where we can see the kidney tissue and we can see lots of inflamed cells, which is the purple dots. And we work very closely with kidney pathologists who tell us about the levels of inflammation in the kidney. And that helps us decide whether we need to calm the immune system down with treatment, or whether we can see any scarring and damage within the kidney. So who do we worry about in people with IgA vasculitis and kidney involvement? We worry if there's lots of protein in the urine. And we worry if there's especially lots of protein in the urine that it's causing people to get a little bit swollen. So you can see this picture of this boy here where he's got swollen eyelids, and sometimes we see swollen ankles. And if there's lots of protein leaking in the urine, your blood protein level will drop and you will get some swelling, usually around the face, but sometimes elsewhere in the body. And we call this nephrotic syndrome. And we worry if there's lots of protein in the urine causing this nephrotic syndrome. We also worry if the kidney blood tests at the beginning are abnormal, suggesting that the kidney filtering isn't 100%. And sometimes that means that we don't ever get the kidney filtering back to 100%. So we worry if the kidney blood tests are abnormal at the beginning. And we also worry if the pathology doctors tell us that there's signs of damage in the kidney biopsy, in particular scars. So a little bit like if you had a scar when you cut your knee or cut your arm, those scars don't go away, and they're areas of damage within the kidney. And so no matter how much treatment we give, we can't reverse if there's scars within the kidney. And so we worry if we see kidney biopsy samples that are very scarred. And so just to summarize with the kidneys, what we see is that by far the majority of people with IgA vasculitis make a complete and full recovery and don't have any long-lasting kidney problems. But we have a small number who go on to have some kidney problems, and some of these get better, or some of them might be very mild in the longer term. But in children, we see about 1 to 2 in every 100 will go on to get irreversible kidney damage. And that means that they're at risk of the kidneys not filtering properly in the future, and there is a risk of kidney failure. And in adults, this is actually more common than what we see in children. So what treatments do we use for the kidney? We use treatments that are used for lots of other autoimmune conditions, and these are treatments to calm the immune system. And we can also use treatments to try and reduce the protein leaking from the kidney, because we know from other diseases that this can protect the kidney. If we need to, we can also treat high blood pressure, and we can treat the fluid swelling, like the little boy who had the swollen eyes. We can treat that with medicines to try and help reduce the swelling that's in the body. And we can also treat the rash or the joint or tummy problems if they are severe or significant, and some of that will be touched in the next talk. Some medicines, especially steroids, have side effects, and we know from previous patient engagement events that patients don't like the side effects from steroids, and in particular we see weight gain with steroids, and we know that patients find this extremely difficult, and so we're very conscious that some of the medicines that we use have side effects that patients don't necessarily like, and we need to look at better ways to treat this. So the future, we still need to learn a lot more about this disease. We know that the IgA molecule probably drives the immune system, and there's something abnormal about this IgA molecule that means your immune system launches an attack against it. But we don't understand exactly why some people get kidney problems, some people get worse gut problems, some people get a really bad rash with no kidney problems. And so there's still lots more that we need to learn and understand about the disease. Importantly, we need to know what is important from our patients so that we can learn what areas we need to improve the quickest, really, how we can get things even better in the shorter term. And I talked a little bit about steroids, but we'd like to hear from people about what can we do that's better. So it would be really useful if people can put on the text chat any difficulties that they've had with medicines, anything about their patient journey that they feel could be better, or what's important for you. Is it that you want the kidneys completely better? Is it actually that the rash is more important and was more worrying? We need to know what's important, because we can only decide as a doctor what we feel is best, but we're not the ones that are living and have experienced HSP, and that's why we like to engage with people and try and find out exactly what it is that the audience feel is important, what you feel is important when you've experienced it yourself. And we also need to look and test new treatments, but also test the current treatments that we have. And there are lots of different immune medicines and ways that we can calm the immune system. And at the moment, we don't know which one is the very best. We think there might not be very much between them, but we don't know if any of them are slightly better, and that they therefore should be the very best treatment that everyone's using. And we also need to look for new treatments, and in particular new ways to use steroids. It might be that we can get away with lower doses by using them in different ways, and we need to try and look at that and evaluate that. So I'm going to touch a little bit on differences in adults and children on this slide, and then ask Professor Salama to join in the discussion so that we can touch a little bit more on adult disease focused on the kidneys. So sometimes we see a delay in the initial diagnosis, in particular for adults. We don't necessarily always see this for children, because I think the rash can be quite striking, that often people will go to A&E, and usually a paediatric doctor will recognise HSP, because most local paediatric A&Es will see probably about 6 to 12 cases of HSP a year. So most paediatricians are very comfortable with making a diagnosis of HSP. But again, this might not be the case for everybody. And if you've had difficulties, then please do share that on the text chat. We usually see actually that children have less of the scarring and damage on the kidney biopsy, and this might be because they've got younger healthy kidneys, or it might be because their immune system is more active, that it presents a bit sooner. But we usually see that actually there's less of the scarring and damage and worrying signs on the kidney biopsy, and this means that often children respond to treatment, and sometimes we see a complete response from their kidneys. Children sometimes, though, have a delay in referral to specialist care, so seeing a paediatric nephrologist like myself, or a paediatric rheumatologist like Professor Hedrick. Sometimes we see that they will stay under their local paediatrician whilst they continue to have kind of perhaps grumbling disease that just isn't going away but isn't getting worse, and there can be delays in that process. And so we'd like to hear if people have experienced delays in that side, so that we can learn about how we can try and make that better and educate our general paediatric colleagues on how to refer young people earlier if they aren't getting better. So I think I'll ask Professor Salama to join in at the moment.
Yeah, thanks, Louise. So I think it's fair to, everything that applies that Louise said to children applies to adults, but I think it's not something that people often think about in the context of adults presenting with an illness. Adults themselves may not take it quite so seriously to begin with. And we do see a delay often with more advanced problems when people come and see us, especially in the kidney department. These are just some data. We did a survey of a number of different UK vasculitis units looking at adults with HSP or IgA vasculitis. And this is just a graph to show you the age distribution that we see. So this is a condition that can present at any age. It's obviously much, much more common in children than it is in adults. But you can see there's a spread in these units of anywhere from, I mean, we tend to see 17, 18-year-olds as our youngest patients, but going all the way up to somebody in their late 80s and 90s. So this is a condition that can affect almost anyone. And it can be delayed because people often don't think of it or don't associate this particular condition with adult patients. The biggest risk for in terms of long-term organ damage is obviously the kidney, and that's something that we take very seriously. When we looked at the patients who we saw, many of them presented with much, much more advanced kidney disease, as Louise said, and we don't really know whether that's because there's been waves of this inflammation going on in the kidney over a period of time, or the older patients tend to have other kidney problems that is then compounded by this episode of IgA vasculitis. So that's all I really wanted to say about the age presentation for the adults. But many of the problems that Louise has highlighted in terms of the symptoms and in terms of what we do with the patients are very similar between the adults and the children.
Excellent, thank you. So thank you for listening for the first snapshot of kidney disease in IgA vasculitis. I'm going to now hand over to Professor Hedrick to talk a little bit about when specialist input might be needed from a rheumatology point of view. Thank you, Christian.
Thanks very much, Louise. Hello, everybody. So this slide is a bit complex and it appears quite busy, but it's basically just to show you that IgA vasculitis is one form of vasculitis we are seeing in children and also adults. Overall, in pediatric rheumatology, we see the same forms of vasculitis our adult colleagues do see, but the distribution between them is slightly different, and also the clinical presentation may vary quite a bit. As Louise already said, IgA vasculitis is a small vessel vasculitis, and what you can see in that orange box is that it's only one form of small vessel vasculitis. So there is a number of conditions that may look relatively similar, and since there are no diagnostic, there are classification but no diagnostic criteria for HSP in the individual patient, this can be a diagnosis of exclusion. And if disease is more chronic, relapsing, or patients are severely ill, we need to consider differential diagnosis from that field of small vessel vasculitis. Next slide, please, Louise. So overall, no, just back one, there was a little insert. Thank you. So generally, you can say that patients should be seen by a specialist, and one specialist may not be enough, because you already heard that nephrologists are very central in diagnosing and treating patients with IgA vasculitis, but so may be pediatric rheumatologists or gastroenterologists or other colleagues. But in cases with remaining doubt, specialist input should be sought. And doubt can be present if a patient is feeling very ill, because overall most patients with IgA vasculitis are feeling relatively well. There may be some degree of fatigue, but usually no fevers or severe signs of illness. And therefore, in such patients, additional diagnosis required to be considered from the field of vasculitic disorders usually. And that applies to most patients. Symptoms last no longer than 6 to 12 weeks. So in patients where you have ongoing disease of more than those 6 to 12 weeks, specialist input may be helpful, especially if treating colleagues are less experienced with the condition. And in general, that's what we say in pediatric rheumatology overall, in cases where the team certainly includes the patient, is concerned, and there is a reason for concern that can be worded, specialist input should be sought. And that doesn't necessarily mean that a patient needs to be sent across the country, but especially now during COVID-19, we learned that online or telephone consultations may be an option in individual patients. Next slide, please, Louise. So as I mentioned, HSP or IgA vasculitis is just one form of what we call immune complex vasculitis. And Louise nicely explained already that immune complexes are basically the combination of antibodies which we produce that bind to antigens. And these antigens can be circulating components of cells that are being released, for example, during tissue damage. And what happens in IgA vasculitis is that these immunocomplexes deposit in vessels, so in the peripheral circulation, where they result in the recruitment of immune cells and activation of immune cells, and lastly, inflammation that can then result in damage. And what you see in the center of this image, that's the purplish pink image, is that vessels can swell up, they can develop significant inflammation, and what you see in the vessel wall, and maybe Louise can point to it with the cursor, is that in and around the vessel walls, immune cells accumulate, and they actually get damaged and die, which is what then is referred to as leukocytoclastic vasculitis, which is another synonym for the group of conditions IgA vasculitis is part of. And in the center top area of this slide, you see an inflamed glomerulus. So this is stained for immunocomplexes, which deposit also in the kidney, resulting in some of those kidney problems Louise was referring to earlier. And one of the most common symptom in IgA vasculitis, so the pediatric definition claims that 100% of patients need to have that, otherwise we can't diagnose as HSP. Or IgA vasculitis is skin inflammation, which usually occurs on the lower limbs and arms, and it can actually be quite severe, as you see in the picture of this child, who even showed small areas of necrosis, which may require additional treatment, especially if patients are concerned and can't live with these skin changes, though they may be overall relatively harmless and resolve after some time. But it certainly raises concerns amongst patients and parents because it's visible, so you can see it and you're being reminded of your condition all day. Next slide, please. So as I mentioned before, immune complex vasculitis is an umbrella term. It can be the symptom of IgA vasculitis, but also of something else. And other forms of immune complex vasculitis include systemic autoimmune inflammatory conditions we are seeing in rheumatology, for example, hemorrhagic vasculitis and systemic lupus erythematosus. And this is why I said if patients feel particularly ill and are not overall well, we should maybe revisit differential diagnosis such as systemic lupus or other forms of systemic small vessel vasculitis. But immune complex vasculitis can also occur during infection, for example, in septic patients or in a meningitis patient. It can be the result of drug intake, and several medications, including antibiotics, can result in immune complex vasculitis and others. That's why your treating physicians in the beginning ask lots of questions, including medication or intake or use of drugs. Next slide, please. There are more or less common additional symptoms on top of skin and kidney symptoms. At least in pediatrics, arthritis, which means joint inflammation, is relatively common. In up to 70% of pediatric patients, we see some extent of arthritis, joint inflammation. It largely affects big joints of the lower extremity. And what's very interesting is that our patients report significant pain in the absence of massive swelling. So this is commonly missed by patients who are less experienced in joint exams. Gut involvement can occur in up to 50% of pediatric patients. Some patients experience quite significant abdominal pain. Usually blood in the stool is not visible. So in patients with abdominal pain visiting our institution, we perform tests for not visible blood, so for very small amounts of blood. And what you can see in that ultrasound image on the right is a significantly swollen intestinal wall. So usually on an ultrasound image, it's really hard to see the intestinal wall, which is only 1 millimeter or so thick. And in this individual, it was swollen to 1 centimeter in thickness. And what you can see in color is a significantly increased blood flow in the intestinal wall as a symptom or a sign of that inflammation. Some individuals develop significant blood loss in the stool, which is then a warning sign and can hint towards complications, which can include perforations, intestinal wall infarctions, or intussusception. And an intussusception is when part of the intestine falls into another part of the intestine. It's a little bit like when you take off a glove and that falls into itself, and that can result in significant complications in children. Next slide, please. Renal disease we heard about. In pediatrics, we see that in about 20 to 40% of all patients, and Louise already mentioned that in most individuals it's not super severe, and in childhood most children, like 98% of children roughly recover from it over time. It usually does develop within the first 6 months of onset, which is why over the first 6 months of IgA vasculitis, patients are being asked to deliver urine samples, which we can test for immune cells, red blood cells, and protein loss. And in individuals with renal involvement during IgA vasculitis, flares may occur later in life during infections, and in women, especially during pregnancy, which is why during those episodes we should test for proteinuria and sometimes the loss of red or white blood cells with the urine. Next slide, please. Then there are certain organ involvements that are less common, but certainly can cause significant damage and need to be treated by an interdisciplinary and experienced team. Generally, any organ system of the human body can be affected by IgA vasculitis. These rare manifestations may involve the testes. So testes can become inflamed in the context of HSP or IgA vasculitis, which can result in testicular bleeds in up to 10% of patients who have inflammation of the testes. There can be obstruction of ureters, so the urinary ducts, which can result in kidney issues as well. I personally haven't seen that before, but it's reported in the literature. Some patients may develop CNS involvement, so in patients with headaches and IgA vasculitis, seizures, or massive fatigue or change of behavior, MRI studies should be considered. And one of the differential diagnoses in patients who develop a coma or a seizure is a hypertensive crisis during renal disease. So it may be difficult to differentiate between the two at times. Lung inflammation is relatively rare in IgA vasculitis, but can result in significant complications, including pulmonary bleeds, which may be life-threatening. And on the right, you see an X-ray of a chest of a patient with IgA vasculitis. And those white areas, part of it is the heart, which Louise may point to with the cursor if possible, but the other more cloudy areas are the reflection of a pulmonary bleed in that patient. Next slide, please. So what can we do when you see a specialist or a combination of several specialists from different subspecialties? In patients with mild or moderate disease, potentially including arthritis or joint inflammation, treatment is mostly symptom-oriented. Some patients, especially with joint involvement, benefit from local cooling or analgesic treatment with paracetamol or non-steroidal anti-inflammatory drugs, such as, for example, ibuprofen. But we need to be slightly cautious in individuals with renal or gut involvement, because non-steroidal anti-inflammatory drugs may also cause issues in those instances. Patients with gut involvement, if gut involvement causes significant pain or bleeds, will receive corticosteroids at relatively high doses over 1 to 2 weeks. There aren't many indications that are proven to be effective, in which corticosteroids are proven to be effective, but gastrointestinal involvement is one of them. In patients with more severe gastrointestinal involvement, especially bleeds or risk of perforation, clotting factor substitution has been used and shown to be effective. And in patients where a perforation or severe intussusception may occur, surgical intervention may be necessary. Honestly, I haven't seen that in my career yet. Usually, patients respond to treatment even with severe abdominal symptoms. CNS disease is very rare, but potentially life-threatening, and here we usually use very high-dose corticosteroids, which we give in the vein, and in some patients more effective, but potentially also more toxic immune suppression. And that's what I wanted to share when it comes to relapsing disease, or particularly severe disease, where specialist input beyond renal may be necessary, and I'm happy to discuss now or later with you.
That's excellent, thank you, Christian, and perfectly on time actually as well. So perhaps we'll move on to Zoe to talk a little bit about support that's available. I'll stop sharing this screen. Support that's available through Vasculitis UK, and then we'll have a brief break whilst people ask questions or think of some questions. Thank you, Zoe.
Yes, thank you. Bear with me, I'm not very technical. I'll start. Yes. So first of all, I would like to thank everybody that is behind this event. It gives patients a great opportunity to learn about the illness, to find out what they have to look for and how to get support. My name is Zoe Anastasa. I represent Vasculitis UK. I'm a vasculitis patient myself. I have GPA vasculitis. I was introduced to Vasculitis UK by my rheumatologist, because when I got diagnosed with an illness I've never heard before, I start Googling around to find what it is, and I got quite scared. So he said, if you want to find information, Vasculitis UK website is the best place to go. I'm still very grateful for that introduction, because not only did I get very good support, but I found a new passion in my life to support other people that are going through a similar situation. So a few words about the charity. The trust was originally formed in 1992. In 2 years, it will be around for 30 years. It was formed to honor Stuart Strange, a young man who died from complications of GPA vasculitis. In 2011, we changed the name from Stuart Strange Vasculitis Trust to Vasculitis UK. Vasculitis UK is run by volunteers. The trustees and the volunteers are either patients themselves or carers of people that have vasculitis. We don't have offices, if you don't count Johnson Susan's kitchen table as an office. And we all work from home. Technology is our right hand. It's my left hand because I'm not very good at this. So what are we doing as a charity? We aim to support people who are suffering from vasculitis, any type of vasculitis, and their families. We provide information and advice. We try to inform vasculitis patients about their illness so they can control it as the best way possible. We work with other organizations and medical professionals, some of you are here, to improve the diagnosis and the treatment of vasculitis diseases. We try to raise awareness, and we give the opportunity to vasculitis sufferers to contact other people with vasculitis. Emotional support is very important, as the diagnosis of vasculitis is not only challenging physically, but mentally and emotionally too. We encourage members to create local support groups. Last but not least, we support research into the causes and effects of vasculitis, and to improvements of the diagnosis and the treatment of people suffering from different types of vasculitis. Vasculitis UK aims to spend at least 50% of the annual income supporting research. And we support research in two ways. We fund research programs. For example, because of the current situation, we recently funded two projects about the effect of COVID-19 on people with vasculitis and the antibody responses in immunosuppressed patients. And we offer support for clinical research because we have a large number of members. We can always encourage patients to participate in clinical trials, or ask our members to take part in surveys or answer questionnaires. You can find more about the research projects in our website. So here's our website. There you can find a plethora of information, and it doesn't matter if you're a patient, if you are a carer, if you're a medical professional, you'll find a wealth of accurate and up-to-date information in our website. You can read about what vasculitis is, symptoms, treatments, guidelines. You can view information about the individual diseases. There are so many different types of vasculitis. You can read about how vasculitis is affecting children, about benefits, about travel insurance. In general, you can find information and advice on just about every aspect of living with vasculitis. We have a helpline, and our helpline is open every day of the week, and we try to answer the phone from 9 o'clock in the morning until 8 o'clock in the evening. Well, we are a small team of volunteers supporting the helpline, so it can happen that you call and you get greeted by our answering machine. Leave your name and contact, and we will call back as soon as possible. People don't only contact the helpline for advice. Sometimes they just need somebody to talk to, a person that will understand how they feel, a person that will empathize with them. I promise you that we are doing the best to help the people who contact us. On our website, you will find our email addresses if you prefer to contact us in writing and nor speak to us directly. So we live in the time of technology and social media. Online support is essential for many vasculitis sufferers. They can share what is troubling them, they can ask questions, they can feel a bit less lonely and that they are not on their own. We are taking part in social media. Vasculitis UK Health Unlocked is a discussion group for people with vasculitis, or for people who have an interest in vasculitis. It is a group that you have to subscribe online, and you can set your own privacy levels. If you are a member of Facebook, you could join the Vasculitis Support UK group. It's a closed group, so everything you post there will only be seen by members. It's a very, very active group, and you will find a lot of support there and peer-to-peer advice. I must admit that I made some friends for life in this group, and there are other groups as well. We have Vasculitis UK Young Vasculitis, that is a closed group for young vasculitis patients, I will say from 16 years old up to 30-ish. And we provide them a safe environment to chat and discuss problems that younger people come across when they get a diagnosis of an illness like vasculitis. There are other groups as well. There is a group for carers, a bereavement group, a pregnancy and parenting group. Furthermore, we support members to create local vasculitis support groups. There are over 30 groups in whole UK. Most of them organize social meetings for the members. So I can say a chat over a cuppa is very good for the soul. I still remember the first time I walked in the local support group of Plymouth, where I live, and I suddenly felt very hopeful that, you know, this is not the end of my life. People live with vasculitis and they live well. Some other of the support groups, they organize educational days. So they invite professionals to talk about vasculitis, and they give their members the opportunity to ask questions. There is a page on the website with all the local support groups and contact details for all the leaders. A vasculitis diagnosis can be overwhelming, not only for the patient, but for the family too. We're here to support you through this difficult time. You are not alone. We are here for you, and together we are stronger. Thank you so much for listening to me.
That was absolutely amazing, Zoe. Thank you so much. Because there's only so much as doctors or even nurses or anybody in the healthcare system that we can do. And I think the support that you've just highlighted is phenomenal. And actually my experience is that you really do empower people to seek that specialist support when they need it, and also to link up people, which gives, you know, extra empowerment because they have other people to support them or other people to share their journey. So I think we'll just have a quick 10-minute kind of break, and we'll come back for half an hour for the magician, and then we want most people to try and engage with the text chat. So think of a comment or a question or something, whether you've had a good experience, bad experience, whether you love steroids, hate steroids, have different medicines. It would be really useful to hear from people. So whilst we have a brief break and the magician, then do feel free to text something. It can be as vague or as detailed as you want, and we'll try and join in, and that will direct the chat for the panel discussion after the magician. And then just finally, we'll talk about the research study and how we're looking for people to help design a research study. And there'll be expressions for anybody who would like to be interested in that at the very end of the meeting, which we hope to finish on time at 12 o'clock. Okay, thanks. We'll meet again at 11.
Discussion and chat on the
It's excellent, isn't it?
Yeah,
excellent. So keep it coming, and then Laura, perhaps if I could get you to hand over to Stephen, and we'll hide our cameras again, so we'll have half an hour of something light-hearted, a little bit of magic whilst we keep the chat coming, and then we can hopefully be able to answer some of the questions, because I'm sure there will be some key themes that are coming up that we can then address. Thanks, Laura. So I think we should cover, first of all, the elephant in the room. And there were a couple of questions asking about coronavirus and HSP. And I'll answer this from a children's point of view, and then perhaps I'll ask Alan to answer it from an adult point of view, because we know that coronavirus affects children and adults quite differently. And actually things for children with coronavirus is looking very reassuring, and it's extremely unusual for any child to get very sick with coronavirus. We don't think that there's any necessarily direct association between coronavirus and HSP, but any virus can trigger HSP. And so in theory, it's another virus. And so if somebody had coronavirus, we could see HSP happening afterwards. If you were a patient with HSP, we don't think children are at any more risk for getting more severe coronavirus. but we do have caution in patients who are on immune medicines, and usually if you're on 2 or more immune medicines or very, very strong immune medicines, then we do say that you are slightly more at risk of getting any severe infection worse than anybody else. So there is a group of patients who will be on more severe medicines that mean that they are slightly more at risk of any infection, and that should be they should be under specialist care, and you should have been notified by your specialist that you are slightly at more risk. And in those patients, we are asking that social distancing is stuck to and trying to avoid kind of group contact at the moment. But like I said, things with children are very different to adults with coronavirus. So I'll just ask Alan to contribute to that discussion, because it's quite an important difference.
Yeah, I mean, I think that we've had a number of inflammatory diseases that have been triggered by coronavirus. We haven't had as yet an increase, I think, in the number of people who've had vasculitis. Certainly across, we've kept tabs of all the adults across the country who've had vasculitis, and I don't think we've had an increased number of cases. And we have been monitoring this through a group that has been sort of collecting the data. I think the main issue really, which is what everyone's really worried about, is what do you do if you're on steroids or on immunosuppression? What's the risk for you? And I think it's fair to say that the biggest risk for bad coronavirus infection, unfortunately, is age, more than anything else that you might be exposed to. And in fact, immunosuppression and autoimmune diseases contribute a little bit more risk, but nowhere near the impact of age. So I think as lockdown is is unfolding and we are being allowed to do more, everyone is obviously cautious and anxious about what they should or could be allowed to do and how much they should be allowed to do. And I think common sense here is, if you're on immunosuppression, if you are older, then try and keep yourself to yourself as much as you can. Wear a face mask if you're going out. Keep washing your hands when you've been outside and exposed yourself to other areas, and try not to get into areas where there are lots and lots of crowds. But we don't really know the individual impact of different immunosuppressants contributing. From rheumatological data in adults, at least, the number of immunosuppressants don't seem to have a particular propensity for giving bad coronavirus. So I think it's sort of common sense stuff. I don't think it's triggered vasculitis as such, but obviously, as Louise says, any viral infection can do it, but we haven't seen a massive spike in it as far as I know.
Excellent. And there's just one more question popped up to say, are children with IgA vasculitis at risk of having the severe inflammatory response to coronavirus? And maybe Christian can just chip in with that if he's still.
Yeah, thanks. It's in the end, like, we need to be honest, the data we can access is relatively limited, and it will take weeks or months to sort through the data we have right now. So we are all trying to look at our patient charts and compare patients and summarize them. But we really can't give a final answer to that. One thing that was apparent in our cohort in Alder Hey, which was like 15 patients with hyperinflammatory syndrome in childhood, one of who was very severely ill, is that lots of those patients, if not all, had an activation of the clotting cascade. Most of them had circulating immune complexes, low complement. So these are features you will also see in IgA vasculitis or immune complex mediated disease. One of our patients indeed developed IgA vasculitis that was timely limited. It was like 4 or 5 weeks. She didn't have severe renal involvement. It all resolved as it would in most patients with IgA vasculitis. So it's not a surprise that we do see them, as Louise said earlier. How frequently that does happen, if it's more frequent as compared to other viral diseases, we just don't know. We'll learn in the future. And I know this is a very unsatisfactory answer, but it's the best I can give.
But so, Christian, I think it's fair to say that at least in the adult population, the people who've had the very severe hyperinflammatory disorders haven't come from one particular diagnostic group. So it's not that those patients have been people who've had autoimmune diseases or they've had something else underlying it. I don't think there's been a theme. It seems to be, I mean, obviously we will find out what the risk factors for it are, as you say, in the future, but there seems to be a very small minority of people who get this very inflamed reaction to coronavirus. But I don't think there is a diagnostic group that we can label to say that you're at high risk of doing that. So I think in terms of reassuring the parents of IgA vasculitis children, I would say the risks of first of all, of contracting coronavirus, I don't think coronavirus has necessarily triggered an increased surge of vasculitis. And I don't think there is a risk of getting worse coronavirus as a result of that underlying disease. The treatment may contribute to some susceptibility, but I don't know that we really know how much of that contributes. And I think age is a great protector for the kids in terms of the coronavirus.
Absolutely.
Yeah. Can I just add one more thing? Like, data is very limited on the association of severe disease with autoimmune inflammatory condition. And as we heard before, there are some studies suggesting that the risk of developing severe disease in adulthood is increased. There are other studies suggesting that it's the same. There are studies suggesting that it's lower. To be honest, we don't know. We're not massively worried. I could even argue that it may be increased for a person on strong immunosuppressive treatment, that you develop disease. But then I also think that there are lab data particularly suggesting that if you are on that medication, you may get infected more frequently, but your outcome may be better because you won't develop that hyperinflammatory phenotype, because these drugs are also what we use to treat ITS patients who are very sick and they get better. So I think
there's a lot of unknowns, but some of the medicines like steroids and that are being used for the severe inflammatory response.
Yeah, exactly right.
It could be that some of them are protective, but we don't know that yet. And at the moment, most doctors are being slightly cautious if you're on a number of immune dampening medicines, I think is kind of fair to say. But what we do know is that children are very unlikely to get severely ill with this. Even the hyperinflammatory response is extremely rare. So we'll move on, I think, because the world is taken over by coronavirus at the moment, and there's lots of other questions. Some quick ones to address is people saying about flares after exercise. We do see flares after exercise, and especially sometimes high impact exercise on the ankles or on the legs. We sometimes see that, but that's not to say that people should stop exercising. We like to encourage exercise and healthy living. And we basically usually tell children to do what they can cope with and within what's reasonable for pain and swelling. So obviously if they had swollen ankles or sore ankles, then that's the time to rest it. And when they've gone and got better, then that's the time to try exercising again, or try less impact exercise if you find that it's a certain type of exercise that tends to trigger it. Another question that came up was, a 22-year-old who's been on long-term steroids and worried about the side effects, and are there other additional medicines? Perhaps Alan could take that, even though it's not specifically renal, but there are steroid-sparing medicines.
Yeah, I mean, I think, we're all sympathetic to the idea that long-term steroids is not something we would want patients to be on if we could help it. And so there are a number of other medicines. You've spoken about colchicine, but it didn't sound like that was doing enough. But certainly in terms of the protein leak from the kidney, we would suggest that you might go on something that would help reduce the protein leak, which is a group of drugs called ACE inhibitors or angiotensin receptor blockers. And that's probably something to have a discussion with your doctor. But there are specific immunosuppressants that would allow you to reduce the dose of steroids quite significantly. And they're drugs other people have mentioned them, such as azathioprine or mycophenolate. And again, that's a very individual choice. Something suits some people better than others. And it's a question of talking to your doctor about that and figuring out what the best treatment for you would be. But I think generally a lot of us now feel that long-term steroids are not the way to go, and that minimizing the steroids and using something else to achieve that is really important to do.
Excellent. So a few other quick ones. People describing the rash being quite bruise-like and recurrent bruises, which we do see. Usually there has been some element of the purpura, the pinprick spots at some point, but we do sometimes see bruising type rashes. Fatigue is something that's commonly reported and often ignored by lots of people and can be very frustrating, but that is something that is recognised, and actually probably more recognised in the support groups rather than in the medical setting, when we focus a lot more on different organs being involved. But fatigue is something that's quite important. Anxiety again, and sometimes anxiety about the unknown or not being listened to can be a contributor. Some side effects about steroids really, and getting that confused with what is normal teenage mood disturbances, what might be HSP and what might be steroids, and we often get a very muddled picture, and it can be extremely difficult having a growing child on medicines, or even having an adult who's working and got other demands whilst you're trying to take some medicines that might have side effects. There were one or two comments about sinus problems, and I thought maybe Christian could comment on this, about whether any further tests might be needed if sinus problems were there, because sometimes they can trigger other stuff.
Yeah. So yeah, so if you have sinus issues for multiple reasons, you should be seen by a specialist, because like other forms of small vessel vasculitis can come along with sinus issues. So that is definitely a thing that should be revisited. GPA, for example, which is a severe form of vasculitis, can start with sinus involvement, and actually in those cases, especially in children, comes along with long diagnostic delay. It's extraordinarily rare in children, but it shouldn't be missed, because that can have massive consequences. And then if it's just like chronic sinus inflammation or infection, that can obviously trigger prolonged courses, should be addressed by ENT colleagues.
Excellent. And there are a few comments about can be a trigger for IgA vasculitis. So lots of people are recognizing that, which is really good to hear, because that is usually what we see, is that there's some kind of illness beforehand. And that fits with people saying about fever with flares, is that usually there's a viral type illness which could be relatively mild, or a fever that's provoked a flare. So the fever isn't usually associated directly with the vasculitis in this type of vasculitis, but it's usually with a virus or something that's triggered off the flare. Some people talked about the skin biopsy test, and when we might do a skin biopsy test, and that's usually when people are not certain about the diagnosis. And so if you had slightly unusual disease, or disease that was going on for a longer period of time, then we might do a skin biopsy test, and that would usually only be done when the rash is still very active, because the lab people need to actually see the active areas of skin. They can't just do a biopsy test on a normal area of skin. And certainly it's usually our teenage patients who run a slightly more longer course, and perhaps a bit more like adults, where we often do a skin biopsy just to confirm or help us to know that this is definitely IgA vasculitis. But on the whole, it's relatively unusual to have the skin biopsy test, and it would certainly only be done when the rash is still very active. A few people were talking about tummy pains and fatigue and stuff not settling within the first couple of months. And like Christian mentioned in his talk, that it's usually that the disease is settled after kind of 6 to 12 weeks. But actually most doctors will probably wait a couple of months to just let it settle itself down. And we sometimes see if the general trend is that things are improving, then that's a very positive sign. So if things in the first year are generally improving, even if there is flares and things are up and down, then usually that's a good sign that this will go away and often will settle completely. But again, every patient is quite individual. It was a very good comment about whether there are any support groups for children. And I think this session today has highlighted that perhaps that's something that we need, or we need to think about a little bit more. And we'll take that away.
It's worth saying, Louise, I think that although there is a typical pattern for lots of people, a significant number of people that we end up seeing are the ones who don't have that typical pattern, who have this sort of stuttering course, often where the rash comes and goes and comes and goes, and then takes a little bit of time to settle and takes longer to settle. And certainly, as Louise says, maybe even taking up to 8 to 12 months for things to really disappear and go back to being normal. And I think not worrying about that. I mean, obviously making sure that there isn't anything else driving it, but understanding that people are slightly different, and that for some people that sort of slow tailing off of the inflammation can occur.
Yeah, brilliant. And then I think last question really about some supplements and omega-3 to help the immune system. Is there anything else? And generally there aren't any non-medicine things that we would recommend, but multivitamins do no harm, and some of the medicines like omega-3 do no harm. There is, some people sometimes talk about fish oil with a similar condition, IgA nephropathy, and again, they don't do any harm, but there are no strong evidence that they significantly help the immune system. So they're certainly not to replace immune dampening medicines, but if they can be taken during the initial bit if you feel that they help, but there is no evidence to support any of those additional medicines. And often in children, we just say to prioritize the medicines for the ones that they need, because it's not often easy for children to take medicines regularly. So we have no issues with people taking vitamins and supplements, but there isn't any evidence that it helps in any significant way. And I think we've covered most things. If anybody has anything that crops up that we haven't discussed, then please feel free to get in touch with Laura and we can try and address it. And we won't be dealing with specific medical questions or cases because we're not your own doctors, but again, if there are themes or anything that you feel hasn't been addressed, then please feed that back. So I'm just going to very quickly share a slide or two about how we are looking for people to help us. And then we've got just a feedback voting thing that Laura will do on the screen shortly. So I'll just see if I can share this slide. Can you see the PowerPoint?
Yeah.
Yeah. Okay. Okay, so whilst we've got everybody online, I think it's important to also discuss about the future. And we're planning a trial called the Pinpoint trial, so named after the rash where you get pinpoint rashes, and it does stand for a very long phrase, but basically we're trying to look at what medicines to use for people who have kidney inflammation in IgA vasculitis. And we're doing this because we looked at an audit last year of all of the children's centres across the UK, and I know Alan's found similar stuff in adult centres, and we looked at all the medicines being used for young people who had biopsy-proven kidney inflammation. And what we saw was that actually there were over 15 different treatment recipes being used by different doctors across the UK, and that's because we don't really have the evidence to tell us which exact recipe is the right one for patients. And so lots and lots of different ones are being used, and lots of people are reporting that their patients do really well. So we all believe that they work, but we don't know whether one works slightly better than the other. And so what we've been doing over the past 6 months or so is trying to get these 15 different treatments down to just a couple of treatments that we can then begin to evaluate in a clinical trial or a research study, so that anybody in the future who had kidney inflammation from HSP could then go into a research study to compare the different treatments and find out which one's best. And so what we're looking at the moment is designing a trial to compare the medicines to see which is best. And this will include some important questions about, firstly, whether we need steroids or whether we can cope without steroids and use other medicines. And then which immune dampening medicines seem to be the best and also seem to have the least side effects. And it will be open for adults and children who have biopsy-proven HSP nephritis. And so what we need is help. We need to know how to design this so that it will work for patients in the future. And we're looking for about 5 patients or families to help us design this study. And we're going to hold a small group event in August, again, a little bit similar to this setup on Zoom, so that we can have a more in-depth discussion about comparing medicines and what should we be looking for when we compare medicines. So what would make you feel like your child or yourself is better? And what would feel like a bad side effect from medicines, and we need to hear from people who have had medicines for HSP. So we're ideally looking for carers, patients, anybody, and it can include young people with their parents, who've had HSP, and ideally those who've had some kidney inflammation and who have needed treatment. But we're welcome to anybody who's interested really to help us to take this research study forward so that we can get it into a package that's suitable to apply for funding towards the end of the year. And we would be applying for a big charity, research charity funding to try and get a trial which would be set up in the next few years. So if anybody is interested in that, then I would be really grateful for your help, and really grateful if you could email Laura on the same email that you got in touch about this event, so that we can see whether you would be suitable and whether you're available on that date. And even if you're not available, then if you're interested in helping in the future, then that would be really good. We need people along the journey of this so that we can do it together, because we know that research studies work much better when we've done them together. So that's the last thing to share. I'll just stop sharing my screen now. And then if anybody has any comments or anything, then feel free to post them. And I'll just ask Laura if she can start the feedback poll so that we can just check whether it's worked well today, and whether this is something that we should hold again. Thanks, Laura.
Are we allowed to fill that out, Louise?
I've got no idea.
I definitely enjoyed today, I can tell you that much.
Everyone can fill it out.
I think we've learned some new magic.
Yeah, we've definitely learned some new magic.
Yes, I enjoyed it too, very much.
Thanks, Susan. I think we're just waiting for a few more votes.
You should stop it as long as the feedback is positive.
It doesn't work like that.
Okay, yep, we're at 100%, so I'll end that poll now.
Excellent, thanks, Laura. So I think we'll all just finish from the panel by saying thanks for attending. We can share the results there, which, you know, most of them have said I enjoyed the session, the majority learned something new, and also that it should be a yearly event. So that's something really positive for us to take forward, and we will take some of the other ideas about young people's groups and support groups and stuff, and see what can be done in that regard too. I think we can share the results, that everybody should be able to see them, which is very useful. And I think we'll finish now by saying thanks everybody, and thanks to the members of the panel who've helped today, and thanks especially to Laura behind the scenes who's been driving it and also been coordinating everybody attending, and amazing Stephen, who's probably already checked out, but that was something unusual and new and different to add to the mix today. So thank you everybody, and thank you Vasculitis UK.